Let's talk about the Geriatric or rapid assessment. These all do a very quick assessment in terms of the domains of cognition, physical functionality, and psychosocial function. We will talk about a few of those elements. The strategy for rapid screening focuses on functional status. Remember the activities of daily living and instrumental activities of daily living. Those are now combined into a short questionnaire. Do you need any assistance with walking, bathing, or meal preparation? Meals on Wheels would be a meal preparation. Do you have issues with management of medications? A big one is household finance. People that have early cognitive impairment tend to have problems with either their taxes or bill payment. With mobility, you can do your own timed up and go test or the gait speed test. You could either do it in feet or meters, preferably the meters. You convert that. If it's less than 1 meter per second, then you know you've got a positive screen for future falls. For nutrition, simply asking or identifying the consecutive weights, you can identify unintentional weight loss. The rapid screen would also include vision testing, so being able to read small print, as well as achieving at least the 20/40 Snelling chart vision test. With hearing, you can simply ask the patient whether they have any hearing loss. You can conduct the whisper test. For cognitive function, you want to do the mini-cog test. If they don't want to do the mini-cog test, you ask them to name some animals. Maybe some farm, jungle, or zoo animals. They should be able to recite at least 12 or more animals within 60 seconds. A lot of times, you'll find people with a cognitive impairment may repeat themselves. They'll repeat cat and dog, maybe they'll mention a zebra. That redundancy and repetitiveness sometimes will be identified through what we call category fluency. If you have somebody that's a mechanic and familiar with cars, you can ask them to recite all of the different models of cars that they can think about. You give them the benefit of the doubt as to what they can potentially accomplish with their category or object naming. With depression, it's established that the PHQ-2 is a very quick test. This can be done by intake personnel when patients come into the clinic. It could be done by the med tech, the nurse, as well as the provider. It's a simple questionnaire. Notice the rapid geriatric assessment. There are different questions that have been produced by St. Louis University. You can see it covers a frailty question. This is more targeting geriatric assessment to identify what we call geriatric syndromes. It looks at frailty, sarcopenia, nutritional deficiency, and cognitive deficiency. Also added to the rapid assessment are questions about constipation, incontinence problems, and then also advanced directives. Looking at primary care strategies for geriatric assessment, there are different approaches. Some advocate a pre-office visit survey. If you contact the informant, there's a cell called TICS for cognitive impairment. That's the telephone cognitive impairment test where you ask if their spouse is having any problems with memory. That might prompt, if it's a positive screen, some further testing. To improve efficiency, you can add the PHQ-2 and gait speed. That's what we're doing in our clinic to the vital sign intake. Basically, you can train different members of the staff as part of the team effort. There's interprofessional cross-activity. Pharmacists have conducted mental status test exams. They do other things in terms of medication screening. The social worker, for example, may do cognitive testing. The handoffs for each of the geriatric assessments can be done according to the person's comfort level and knowledge of conducting those tests. There are telehealth options for a lot of geriatric assessments. Various geriatric telehealth encounters are being piloted. There's the option of doing telehealth geriatric assessment with a visiting nurse or caregiver. There's also the option of doing the testing directly with the patient. The former encounter, where there's somebody helping, whether it be a caregiver, a health worker, a direct healthcare worker, such as a certified nursing aide or a nurse, tends to be a little bit more strategic and valuable because they can help do things like assist with the gait speed analysis. In your primary care practice or in your hospital practice, It's always important for each clinical encounter to identify the geriatric 4Ms. You want to look at what matters: medication, mentation, and mobility. As you screen for these, you might look for opportunities to deprescribe or to de-escalate the dose. There was a patient who was on a massive amount of 3-SSRIs for depression that wasn't clearly stated on the chart. Somebody had given this individual high-dose trazodone for sleeping, which is actually wrong. You're supposed to give low-dose trazodone for sleeping. They were on a high dose. They were set up for serotonergic syndrome. De-escalating the doses was an important accomplishment because patients get tied into their medications. You, as primary care, have total authorization to change your consultant's medications. It's important to de-escalate medications because it improves safety and mobility. If somebody screens negative for fall risk, you can certainly talk to them about physical activity with the target goal of 8,000 steps daily. They should also be performing twice weekly resistance training. That may just be standing up and sitting down 10 times and repeating that 3 times. In terms of mentation, if somebody's screened positive for a memory impairment, you have opportunities to talk about tighter blood pressure control. There's dual task training where you have the individual account backwards while they're walking. That helps improve the spinal cord reflex for fall prevention. They should also engage in cognitive games. Improve nutrition leaning more towards the MIND diet or the Mediterranean diet. For what matters, if they don't have their advanced directives, make the referral for an advanced care planning. That's important in getting that documented. Practice the 4Ms and then come up with management plans that are consistent with what matters to the patient. In case of acute functional decline, most of it in functional older adults is very insidious and very gradual. They get to the point where family members and even the patient don't recognize that they've really reached some thresholds of frailty, or what we call pre-frailty. With an illness, such as acute exacerbation of heart failure with normal systolic function or diastolic heart failure, that can really lead to a functional decline within a short period of time. The recovery period is always a problem. We say in geriatrics, as kind of a rule of thumb, for every day in bed in the hospital, there's 3 days required of recovery. If you figure that out, somebody's in the hospital for on average 5 days length of stay, you can estimate it's going to take them 2 weeks to recover to their pre-hospitalization status. Depending upon the class of, or the conditions that the older adult has, for example, with the second point of frail individuals, a third of them will acquire a new disability in the absence of any illness or injury. This comes on without warning. These are important. Sometimes they are precipitated by a fall, but other times you're not quite sure what led to the change in functional status. An important element to remember is this third point. Return of function, particularly after hospitalization, will occur within 3 to 6 months. There was a Japanese study that found the cutoff was 3 months. So if you didn't recover from your disability after a 3-month post-hospitalization period, it was highly unlikely that you would recover it thereafter. You've got a really short window of recovery. It's so important to engage families and the patient in a very aggressive, steady, and consistent rehab program. Most people who have an acute functional decline, older adults over the age of 75, in particular, barely can lift 2 pounds of weight. That gives you an idea of how functionally impaired they are post-hospitalization. In summary, for our geriatric assessment module, geriatric assessment intends to focus on functionality. In other words, function of brain, physical function cycle, and emotional function. It's intended to promote wellness and independence of the older adult trying to expand what we call healthy lifespan. Geriatric assessment is comprehensive and includes all the domains that we talked about for our functionality. If the major take-home message for you from these presentations on geriatric assessment is applying the 4Ms, that would be wonderful. With each clinical encounter, if you just write down, or if you have a DOT phrase that populates the electronic medical record that includes what matters, medications, mobility, and mentation, You'll be well ahead of the game in working competently with the older adults in your clinical encounters. Finally, outcomes from research shows that geriatric assessment will lower acute care usage and improves the quality of healthcare. It's at a huge effort that we're trying to lower costs and improve quality. Here are some resources. You can refer individuals to the EOS Administration on Aging for Older Adult Services. A lot of states have specific referral opportunities. For instance, in North Dakota, where this talk is emanated, from there, the state supports what's called NDC3, North Dakota Chronic Conditions ×3. NDC3 is a website that allows older adults and providers to identify community-based health promotion programs. For example, silver sneakers or referrals to the Stepping On program for falls can be identified through the website. We also have our HRSA website, or our Geriatric Workforce Enhancement Program. If you go to our website, Dakota Geriatrics, we have lots of different clinical tools, training sessions, and so forth. You can enhance your care and assessment of the older adult. With measurement of quality of life, this often doesn't show up in our clinical programming, but it's important for research. If you're interested in quality improvement doing evaluations, such as the short form, it will help assess different functionalities, including pain, social function of vitality, and all these elements that are self-reported by patients to see if your program and doing geriatric assessments really has an impact on self-reported health. This gives you a breakdown of the different items that are associated with the SF-36. Again, this is a very good tool that you could use biannually to monitor an older adult population to see whether their perception of their health is stable, improving, or getting worse. That's all the roles that geriatric assessment has. To move the needle on the SF-36 outcome measurements would be one of the goals that we would hope to achieve if you're looking at a population health perspective for applying geriatric assessment. This is the end of the presentation. Feel free to refer back to Dakota Geriatrics for additional online training. We appreciate your attention for applying geriatric assessment to your clinical everyday practice. Thank you.